start this webinar. So good morning, everybody, to those of us who joined after I started my little chat. I just want to thank you very much again for joining us. You'll see that we've got a panel that's ready for you. We are going to allow the panel to present before we allow any Q&A. Please, if you do have questions in the interim, put them in the chat function or put them in the Q&A box. And if you really ask your question directly, put up your hand. Your hand function, it's next to your name and it's at the bottom of the screen, and it will indicate to us that you would like to engage with the panelists directly. So this morning we're very privileged to have Nick Hudson and Peter Castleden with us. Nick and Peter represent an organization shortly known as PANDA, which stands for the Pandemic Data and Analytics Group. And this group has been, or comprises of actuaries and an economist, doctor, lawyers, statistical lecturers, and data specialists, scary combination. And they've been doing a lot of work around the mortality rate versus the economic impact of COVID-19. And they've also presented these findings to the presidency. And we thought it appropriate to have Nick and Peter join us this morning to share with us what they've been up to and what those findings, what the key outcomes from those findings are. So without further ado, I'm going to hand over to you, Nick and Peter.
Thank you very much, and thanks for inviting us to do this webinar. It's a real pleasure to be sharing our work with colleagues from the industry. I'll start off by just providing some background to how PANDA came to be, why we started this initiative. It has its roots in conversations that I was having with a few concerned people in March, middle of March kind of thing. We shared a sense that the whole way in which not just South Africa, but the world was looking at this pandemic was flawed in many ways, and that the risks involved were not being assessed properly. And just to put that in a little bit of context, I mean, there are two parts to the equation, really. There's the question of, are we looking at the pandemic and its characteristics, the disease and its characteristics correctly, and interpreting them correctly from an epidemiological and actuarial perspective? And then, are we looking at the economic impacts of both the consequences of the pandemic and the reaction to the pandemic in the form that it has taken, which is these very elaborate and extensive lockdowns that are being seen all over the world. And I guess, you know, sitting at the juncture of actuarial science and private equity, especially middle market private equity, I was kind of acutely exposed as a person, just in a sort of a unique little place where I was getting firsthand experience through my origination network of these businesses that had just a couple of months ago I wouldn't even been able to afford to look at, were now available on the market for $1. Entrepreneurs basically just throwing in the towel and giving up on you know, many decades of their labors. And I found that terrifying. I really did. I could just see the scale of institutional destruction that was taking place was off the charts, unprecedented stuff. And it really worried me that economists were interpreting this through the lens of business cycle and imagining that you could just roll out some or other stimulus package and breathe life into the shattered corpses of these companies. And at the same time, I was looking at the data from an actuarial perspective, and a strange thing happened. We had that Diamond Princess cruise ship with a very tragic situation on board, with all these sick people, dying people on the ship and not allowed to get off the ship and trapped on board with this disease floating around, a very infectious disease floating around. And it grabbed the world's attention and certainly grabbed mine. And after a couple of weeks, the data started emerging from that, and I had my hands on that very quickly. And then one of the strangest things in my life happened, because I looked at that data very carefully and came to the conclusion that this pandemic would not be a major thing. And I believe I was right and wrong at the same time. I was right in that the data that emerged and the way I was interpreting it has actually come to bear. We have a much smaller pandemic on our hands than was inferred by the the World Health Organization, by the famous Neil Ferguson, formerly of the Imperial College. The pandemic has just not panned out anywhere near the scale that was envisaged at the beginning of the process. That's number one. But where I was wrong is that I missed the potential panic that the pandemic would set off. And I think we really are facing two pandemics. There's a pandemic itself, the coronavirus pandemic, and then there's a pandemic of madness, which is the kind of, I believe, deeply irrational and overwrought responses to what is no doubt a tragic situation. Anytime people are dying, it's tragic. But we are taking actions as a world that are going to result in far more tragedy than the disease itself. And that was actually one of the key points of this research, which we'll get to just now. So this conversation began. There were a few of us having it. We started thinking, well, okay, there's this lockdown now. It's going to be 3 weeks. It's going to do some damage. There's nothing we can possibly do to stop that from happening. We disagreed with it. We could understand why it was being done. The whole world's locking down. Let's get this thing under control. Let's prepare the healthcare system. Fair enough. Okay. When the lockdown was extended, despite the fact that we hadn't seen any exponential growth in cases or disease or deaths, we were very surprised and began to become even more concerned because of this rash of business failures, job losses that was being witnessed. And I started fishing around on social media to see if there were other people. And the crucial turning point in that whole exercise was I stumbled across Peter, who I didn't know more than a couple of weeks ago, and just saw that he was seeing exactly the same thing. And here was another actuary, even closer to the numbers. He's a bona fide life insurance actuary. He heads up a business, hasn't worked as a sort of a data actuary for many years because he's the boss. But here was a guy with saying exactly the same things, and I was terribly excited. So I found a way to get in touch with him, and we began talking about putting together this first research report, pulling in people who could help us do it, which was a very important step. This kind of, you can't, this idea that's floating around out there that you should shut up and listen to the epidemiologists is one of the biggest loads of nonsense I've ever heard. A pandemic is something that touches all aspects of the world. You need to approach this kind of problem with a diverse team and a top-notch team of people with lots of skills. So we brought in actuaries, we brought in an epidemiologist, we brought in a infectious diseases specialist, we brought in statisticians, data science people, NGO people who could access people on the ground in the townships and found out what was actually happening, because the news reporting of the township situations has been very hard to parse. And it's quite, on the one hand, it can be quite alarmist, and on the other hand, it can be quite negligent, just missing the stories that are going on. So we assembled quite a big team quite quickly, and then all credit to Peter, who has this amazing ability to pump out this kind of modeling work, galvanized the whole team, pulled the resources together, and started working on our first report. And the important point of this report is that we tried to address this terrible problem that we thought was exacerbating the policy reaction. There was this idea out there that it was wrong to sacrifice lives for the economy. We thought that was one of the most vacuous ideas, one of the most naive ideas that anybody could possibly have. What is the economy other than an engine that supports our lives, that sustains our lives? And we have this lively idea as actuaries that when you go through a severe economic contraction, that has a death consequence all of its own, and it's a severe one, as Peter will explain to you just now. He's much better at talking through the stuff than I am. And we wanted to change that narrative. We wanted to show that this was a lives for lives question, and that people who were framing it as a lives for money or a lives for economy, as a lives for economy question, were being deeply destructive to the point of evil. We wanted to get rid of that narrative. And so we put this paper together and started in the process. While we were putting it, we were also putting out our feelers to the NICD, trying to alert them to this kind of issue, trying to bring to their attention our concerns with the modeling of the pandemic, which we thought was, it entailed a number of key flaws. Those are not the subject of this paper. They're a subject of a forthcoming paper. And so we got going on that and started trying to reach out to people, business leaders, NGOs, the NICD, government. And we found all the time just unresponsive, closed doors. So we hired a communications consultant to help us to get this message out. And that was when we started firing off the letter to the president. And ultimately what happens is our work started leaking a little bit, and we then went live with a media strategy, which was a bit earlier than we expected. And this thing has taken a life of its own. There's been an overwhelming positive response from the actuarial community, both locally and abroad. We've had contact from actuaries in other countries who want to replicate the work in their countries and are recommending to policymakers there that this kind of analysis be undertaken. And we've had an incredibly engaging process with, interested members of the public, interested actuaries, interested doctors, and they've sent in, overall it's been incredibly constructive. We've had lots of suggestions. We're processing them slowly. We hope that we will begin to see a reaction from government in the not too distant future. Our work is definitely being picked up. You can see it in the narrative. The words that we were using in our article are starting to be repeated by notable politicians. Tito Mboweni picked up a couple. Jonas picked up a few in an article today, although we believe his analysis in that article is unfortunately a bit flawed. We'll get onto that. And we have started picking up traction in Business South Africa and other entities that are paying attention to the work. And what that's done is leave us in a very overstretched position. Our team is suddenly, instead of just focusing on the report generation, we're now fielding loads of questions and loads of interest that's been generated here. And it's really putting quite a burden on our time, but we don't mind. We're in this to change the policy debate and to save our country from what we thought was a tragedy of epic proportions due to incorrect policy. So that's the summary of how it all got started. The main piece of work I would like to hand over to Peter to describe, but just to put it in context at a very high level. We perform a bunch of pretty standard actuarial calculations. There's no contestation that that's the way to do the work. This work has been done even by the World Health Organization when they tried to measure disease burden, trying to interpret the cost of a disease in economic terms. So, what would be the benefit of spending some money to cure yellow fever or to vaccinate people in a certain country? They try to persuade their donors to do it because they show a very high return on investment. And so they do these numbers in the reverse order. They go from the years of life lost to a disease to the economic consequences. We turned that around and went from the economic consequences to the years of life lost, which is what life insurers do when they're pricing policies. So it's a poverty kills analysis. It puts numbers to poverty that are mortality numbers. And rather surprisingly, we have one vein of criticism that has come through. I'm gobsmacked about. There are people out there who honestly, seriously believe that poverty does not kill. And we've grappled with this, and the only kind of explanation we can come up with is really it's a bit like, there are members of the Flat Earth Society, because it's just for us astonishing that people have this notion that it doesn't matter. They just, go without an income for a little while, they'll be fine, And very surprisingly, these tend to be academics who are making these points, ivory tower academics. So it's a bit disappointing because that theme has come through a few times, but listen, all I can put it down to is there are some crazy minorities out there. Other than that, people have been very supportive of the principles and the process that we've undertaken. So let me hand over to Peter, who can, the hero of the moment for us and for our team, and who can explain all of this stuff.
Okay, thanks, Nick. Okay, so essentially, like Nick said, so maybe something about the way actuaries think about problems is that we typically have been trained for many, many years to think over much longer time horizons. So what I was getting an intuition from this situation, and I think shared with Nick, and actually most of my actuarial colleagues when this came up, is that there's a tsunami coming, but the policymakers are looking at the ripples on the edge. And so from a life insurance point of view, just some flavor to the situation. So life insurers every single day work out an estimate of people's life expectancies and mortality curves so they can price what they sell. If they didn't do that, they would go out of business very, very fast. And this is actuarial science. That's actually one of the core parts of the profession. So next to age, as a predictor of mortality, the second most predictive factor of mortality after age is socioeconomic class, or I mean, we can just call that levels of wealth or poverty. It's more predictive than smoking. It's more predictive than gender. It's more predictive than pretty much any other factor that we use in pricing. It's so, I mean, and in an insured life population, the difference between someone with quite a high socioeconomic class and someone on the other end of a socioeconomic class is in excess of 500% difference. So to put context, if we have a group of people, there's 1,000 in the group, we might predict at a top class, 1 out of that 1,000 might die. If you take the exact same group, same age profile, same gender, same everything, but in a lower socioeconomic class, it's 6 people are dying. So it's an undisputed fact that the poorer you are, the worse your mortality outcomes. I mean, like Nick, I'm astounded people can argue that it's not a causative relationship. And the criticism we get is that we so easily jump to the conclusion that poverty causes it because it makes sense. Yes, well, of course, because it does make sense. I mean, actuaries don't have to explain why data tells stories. We use the stories. We don't necessarily spend a lot of time speculating on why. But it's worth probably going into some of the reasons why poverty kills. And this is also entirely predictable. Worse nutrition has poorer health outcomes, especially in children. So poverty also has a disproportionate effect on children and childhood mortality. Malnutrition is severely bad for the long-term outcomes of kids. Poorer living conditions. So, I mean, in poor areas, you can't press an ADT button and get sorted if there's crime. About a year or so ago, I was looking at the crime data of South Africa, and there's pockets in Cape Town, very, very specific pockets of Cape Town, whose death rate from murder exceeds a war zone. This is not an exaggeration. So that socioeconomic class in that area is fairly consistently low. So that kills. There's also substance abuse. There's also more. So, I mean, there's a million reasons. Oh, and then the big one, access to healthcare. So life insurers don't model this because it's would be unpopular. But if you have access to private healthcare, your outcomes are significantly better than public healthcare. So there's no debate. As far as I'm concerned, there's absolutely no debate that poverty leads to worse outcomes. So what we tried to do, what we realized was going on is that the policymakers are not considering this trade-off decision they're making. It feels like the noise at least in the media, has been around the trade-off for lockdown is the minor inconveniences of the middle class. And that is just a ludicrous assumption. If there were no costs of poverty and lives, I think all of us would happily tolerate curfews and windows of exercise and all the other stuff we would tolerate that because those are largely inconveniences. But we said this is nonsense. There's actually a much, much, much bigger cost we're paying here versus what we stand to gain from the lockdown. And I want to touch on that one a little bit later. So the way we did the calc is fairly straightforward. This is where the economist on our team helps a lot with the assumptions. So his position, and I think we're seeing this, and Nick sees it every day in business, is that this is not a business cycle. These jobs, many of these jobs, and there's millions are going to be lost, there's no debates, but many of those are going to be lost as good as permanently. Okay, so we didn't model that they lost forever because you obviously the further time out you look, the less confidence you can have in any assumptions because things change, right? So we said, well, there's a proportion of jobs that are going to be lost permanently. Those people are definitely going to be moving down a socioeconomic class, if not more. I mean, actually a lot more. So we were very conservative in the assumption. And it might be worth pointing out that when I was doing the modeling, so when you have an intuition, typically, and you want to build a model to prove you're right, you should actually build a model to prove you're wrong. So when you build the model, try and prove the opposite case. So in doing the maths, I was trying to prove that lockdown was worth it. And despite that, as low as I could get the numbers, as conservative as I could make them, the trade-off is 29 times. That's what we show. The reality is the trade-off's north of 100. It's not helpful to publish that because then there's a lot less safety in our numbers, but best case scenario I could get was 29 times. So this is not even vaguely close. So essentially we say there's up to, I mean, we didn't even model huge numbers. 500,000 people or so are going to lose their jobs as good as permanently. They each support 3 extra people. So that's 2 to 3 million people are going to go down a socioeconomic class. You model that with a slightly higher mortality and you add it up. And you say, what is that cost of death? I mean, those people are each losing years of their life based on their socioeconomic class. We can sum those together and we compare that to the years of life lost on what we're gaining from lockdown. So we don't concede that lockdown has some, on a very narrow focus, has some positive gains. Clearly, spreading the burden on healthcare saves lives. I mean, we don't dispute that. We actually assume that they save a lot more than we think. Like I said, we were trying to make this number, this case strong. So on the one side, we assumed the most optimistic case of lives that could be saved. And the other side, we assumed the most optimistic case of lives that would be ruined by poverty. So we took the polar opposite of each end of the number and we divided them and got to 29. So in reality, we don't think the benefits of lockdown that we've modeled are significantly less than what we've assumed. And on the other side, we've assumed that the destruction on lives lost is significantly worse. I mean, no, it's significantly better than it will actually be. And so essentially that was the sum. And I probably should touch on a couple of things where the media has been unhelpful in misconceptions. There's no debate. And I mean, if you listen carefully to what the health minister says, there is absolutely no denying that these deaths are coming. Okay, so what we like to say is that the strategy of lockdown is not to eliminate the curve. It's to flatten the curve. It's a very different thing. Flattening the curve and eliminating the curve. Flattening means they are still going to come. They're just going to come a little bit slower. So that's why you'll hear them say, we're expecting a peak in September and October. And fair enough. I don't have any reason to really dispute that. But the deaths are coming. So lockdown or not, there is a whole bunch of lives that are going to be lost irrespective. So using the narrative to say, if we didn't have COVID versus the economic impacts it's a logical, you're misplacing the logic. You actually have to count, what are you saving from lockdown? So what we modeled there was an overburdened hospital, meaning there's a lot of people that are going to not get adequate treatment that they would have otherwise gotten. A lot of people with COVID will actually have worse outcomes if they're overburdened, because the prognosis of this disease is pretty rosy. I mean, if there's certain pockets that are at very high risk, but many people will get over this. Obviously, an overburdened healthcare system means those people that should survive happily, some of them won't. So that's kind of how we did the modeling. And the numbers are astounding. And to be honest, didn't surprise any of us. Most of us were guessing it's going to be well north of 10 times worse. To put it another way, we would need to have about 1 million people dying from this disease to justify lockdown. That's kind of the quantum. And we're thinking it's going to be substantially less than 50,000. So that's kind of what we did. So there's, and the actuarial guys, we've had a bit of some debate on how we set the assumptions, and to be honest, we can change those assumptions drastically without changing the outcome. There's absolutely no way to model this where the poverty loses against the lockdown. There's no ways. I stand by that.
Peter, can I just throw in a couple of points that I think it's important to stress to the audience. The answers from country to country when this kind of calculation is performed will differ quite a lot. Middle income countries are in a somewhat unique position in this regard, because you have always a substantial portion of the population who sit hovering just above the margins of poverty, where you know, a reduction of income throws them into a much worse health and environmental kind of situation. And that is a unique feature of middle income countries, and ours is quite an acutely middle income country in this regard. And the other story is that we also have quite a lot of evidence to suggest that our disease burden overall and aggregate as a population measure is going to be lower. The main driver of that is that we have a population age structure that's very different from Italy or Spain, where you've seen these outrageous situations developing in the hospital system. So, you know, just that age structure effect for our country alone knocks off 2/3 of the deaths per capita relative to a European country with a very aging population, not many children. And then there's also an income effect. Countries, it's very clear from the data at the moment that wealthy countries are the hardest hit. And there's a very interesting clinical explanation for that. Basically, as you go down the income curve, you experience more and more exposure to disease, communicable diseases, and basically poor hygiene and sanitation and food hygiene on a daily basis. And what happens is you get a population that is, first of all, dying younger because of that exposure. So you take people out of the population by virtue of disease exposure. And then the ones who remain have these robust immune systems. And so it's not uncommon, it's certainly not true for all diseases, like it wouldn't be true for Ebola. But it's not uncommon for poorer countries to exhibit lower response to viral exposure because of this immune effect. So it's a well-known clinical observation. And so, you know, when you do this calculation for South Africa, the story looks very different from what it would if you did the calculation for Luxembourg or Switzerland. They'd get to different answers, and, you know, I think it's not difficult to imagine why, you know.
Yeah, Nick, maybe I'll add something on that one, because it's quite interesting. So we also, the findings we saw is that there's going to be a tab that needs to be paid for lockdown, and that tab, unfortunately, is going to be paid by the poorest sections of society. So the way to think about this is, I'm sure most of you are familiar with the quite old economic concept of Maslow's hierarchy of needs. So the more income you have, the more you satisfy your lower end needs, and you start going on fancy holidays at the top of that pyramid. So what happens is, if someone, let's say someone earning 30,000 Rand a month, a year from now, because of economic impacts and whatever, they might pivot and go into business and whatever, they go down 5,000 Rand. They go from 30,000 Rand a month to 25,000 Rand a month. It's not nice. Obviously, people don't like their income going backwards. But the sacrifices that individual has to make this new budget a reality, maybe canceling a gym membership or Spotify or DSTV. It's canceling things that has absolutely no impact on their health. Obviously on their happiness probably, but not on their health. Versus on the other side of the curve, if you are earning 6,000 Rand a month and you earn 5,000 Rand a month, what you are giving up is all the things that are going to help you live. So going down incomes has almost a vertical impact at the lower end of the income, and I think that's true of a country as well. So rich countries, the sums would look very, very different in Switzerland, where pretty much everyone is quite wealthy. If their income goes backwards, it goes down a curve that looks like this, the mortality, whereas at the low end it does that. So that's quite an interesting situation, and it talks to a lot of people are barely above the breadline. You take a little bit of the income away and their outlook deteriorates incredibly fast. And I think that's quite unique. And I think that's why this one size fits all lockdown proposal, I still struggle to see that it makes sense in the developed world, but I buy the argument a lot quicker than I do here. It's going to be devastating.
I think it's a good idea for us to talk a little bit to the economic side of the equation, because, you know, clearly in this setup, the economic impact mediates the mortality impact. So what our economic view here is not wildly out of line with what some other economists are saying. There is sort of a group of economists who have this idea that this is best thought of as in business cycle Keynesian terms. You know, stimulus spending will fix the problem. again, a bit like the Flat Earth Society, yeah, just so obviously not the case. You know, we are talking here about real institutional destruction that's happening. We've seen the high profile ones, you know, EdCon and Comair more recently. But the smaller and medium-sized enterprises here are being absolutely gutted. There's no question about it. So there's a delusional basis out there. There are people who think that, yep, a little bit of stimulus spending, we'll all be back on our feet. It's nonsense. We modeled the economic impact for the whole story. And what I mean by the whole story is the coronavirus itself, with or without lockdown, would have some adverse economic consequences. You know very clearly, people have stopped traveling, people won't go to restaurants. Even if you were not locked down, I think you'd find a lot of people avoiding crowded places because of fear. And the other part of the equation is, okay, well, modulo coronavirus, what is the incremental impact of lockdown? And that is obviously the part that we're interested in. So we're not looking, we look at the whole impact and then subdivide it. And we take a very conservative view there, and in terms of the job losses that are emanating from the lockdown. And it's worth just talking about, you know, for most companies, in the absence of lockdown, it would be business as usual. Maybe a little bit of revenue down, a little bit of some logistics difficulties. So, you know, slightly lower profit margins. The lockdown is an unprecedented kind of experiment. You're turning revenues to zero while costs carry on. And why I say unprecedented, I really mean it. Even in wartime, this kind of experiment has not been tried. In wartime, what happens is production shifts. So your clothes manufacturer starts making military uniforms, and your metals business starts making bullets and bombs or airplane parts or whatever. So you get a movement in focus and energy, and businesses adapt and keep moving. It's not to say there aren't casualties in that kind of process, but they're much lighter than in this kind of process where you just turn revenues to zero. So it's an extraordinary experiment. There's also, you know, just a highly imaginative aspect to the way in which this has been done. That's just strikes us as appallingly naive. There's this idea, it's a rather socialist, Marxist kind of idea, that you have an economy that presents in silos. So you can see this by industry code. Here's a business, there's a business, and I can turn this one off and not that one. You know, the reality is that the economy is a network, a very dense, complicated network. And if you start knocking nodes out of that economy, the effects ripple through the economy. That is obvious. It's known to first-year students of economics. It's ridiculous that our policyholders think they can turn on and off parts of the economy. It's quite naive, almost childish. And one of the astonishing things for me in this whole episode is the extent to which businessmen have backed this whole story. You know, just a degree of removal from reality, which is quite gobsmacking. And so what you've got here is a policy that, yeah, maybe we open this part of the economy or that part of the economy. It's not going to work that way, guys. That's not how it happens. There are still a majority of businesses out there who, all the way to stage 2, are in pretty much dire straits as a result of the policy. And so, you know, the lockdown effects are deep. Don't let anybody tell you otherwise. There is a narrative out there that, oh, it's okay, you know, it's all because of the coronavirus. That's nonsense. If you sit there with a factory that produces some other chemical, that business could run with 2 or 3 employees on site. There's no need for it to be shut, but it's non-essential, so shut. And so on. You know, that was the case with stage 5. I'm being a little bit unfair labeling stage 3 as that, but certainly, you know, there are absolutely bizarre central planning ideas going around. The idea that clothing retailers could sell winter-only clothing. I mean, what absolute nonsense, you know. So now they have to run their stores at even bigger losses in order to just sell 2% of their merchandise. And the immaturity around the pies and the chickens, it was quite silly. So we've got an incredible economic impact as a result of lockdown. But again, we took the light estimates. We wanted work that was beyond reproach in that regard. I see we're almost up for the half hour, 45 minutes. There's one other thing I just wanted to point to. And again, I think Peter might be able to jump in. I'll try with a little quick introduction. One of the huge things, which I think it's important for all of us to stress in our communications with with people across the board is just an understanding of exactly what risk this disease presents and to whom. The numbers in this regard are extreme. For the vast majority of the population, possibly a good deal more than 99%, this disease does not represent a threat to be scared of. Okay, your concern with driving a car on South African roads should be much higher than your concern with this disease. Amongst children, the serious illness and death are so rare as to be fairly described as vanishingly rare. Many of the cases that have been reported upon subsequent investigation turn out to actually have been, deaths while COVID positive. So maybe a child with a severe leukemia or something like that dies while COVID positive, and the death is attributed as COVID positive death. So for children, there's almost no risk. For young, healthy adults, and by young, I have quite a generous interpretation, I would say almost up to 75. For young, healthy adults, the story is very similar. The risks are slightly elevated, but it's nothing to be afraid of. For the vast majority, will not even show any symptoms at all. Some will get symptoms that can end up being, not nice. You'd rather not have them, but the hospitalization rates are low, and the death rates are very low for that healthy group. There's an unhealthy group of young people that are at risk, and they do exhibit, it's becoming clearer and clearer as the data come in, they do exhibit certain characteristics in common. What they have, for the most part, and this is when I say for the most part, well north of 90% of the deaths amongst young people involve chronic comorbidities, and that word chronic is doing a lot of work there. Everybody knows about the comorbidity factor in this story. Chronic comorbidities, meaning ones that you've had for decades. And they're a class of diseases that cause what is known as endothelial damage to your blood vessels. So diabetes, high blood pressure, cardiovascular disease, things like that. So a person who's 45 and has had 20 years of poorly managed diabetes is at risk. A person who's been morbidly obese for 25 years has probably done damage to the blood vessels and is at risk. So there are these risk factors. They're becoming better and better understood, but they apply to a small portion of the younger population. So don't get me wrong, I'm not saying that high blood pressure doesn't apply to a lot of young people. I've probably got some this week, but the proportion of the young population who have had chronic high blood pressure and chronic diabetes is much smaller than the proportion who have high blood pressure or diabetes. When you get to the older people, age itself causes endothelial damage, and the presence of comorbidities alongside old age creates a very lethal cocktail for these old people. And when I say very lethal, I want to just put that in context, because even then, this disease is not a death sentence by any means. Very interesting, I mentioned that Diamond Princess cruise ship. That was a lovely little experiment, horrible for the people involved, but lovely for nerds who like data. On board that ship were I'm just going to talk in round numbers, I haven't got them in front of me, some 3,500 people, 1,500 youngsters, some very few of whom were passengers, most were crew from the Philippines. A goodly portion of them were infected. I think the number was around, can you remember, Peter, was it 20% prevalence in the younger group? Yeah. No deaths out of 1,500, okay, none. 2,000 older people over the age of 65, almost all passengers. And the caricature or the stereotype of cruise shippers, I'm afraid, is 100% spot on. They spend too much time at the buffet. So a lot of overweight old people on board. And amongst those 2,000, there were, despite being in quite close proximity to each other and almost surely having been 100% saturated in terms of exposure to the virus, only 450 tested positive out of that 2,000. So what that means is that around 1,500 of the 2,000 never were infected, or were infected and managed to fight the disease off so quickly before their body even produced antibodies, or before their viral load became high enough to test positive on virology tests. Okay, so that's 3/4 roughly, just didn't get infected. Of the remaining quarter, 250 of the 450 infected people were asymptomatic, didn't even know that had the disease. 200 were symptomatic, and 13 died out of the 2,000. Okay, just bearing in mind, this is a population of people over 65, relatively poor health relative to the average population. So it was an incredibly instructive thing. And that's why I opened the discussion by saying, when I saw these numbers, I looked at them and said, this is not going to be the 100 million death story that people were concerned about. And this is exactly what's played out. It looks like worldwide there might end up being less than 1 million deaths. So we really were not in the hundreds of millions territory, even at that time. And that was, I think, pretty clear from the data, just from that trip alone, let alone the subsequent epidemiological data that emerged. So, you know, it might be an interesting thing for us to discuss later if there's time. How did this idea of this deadly virus that's going to kill everybody, even our children, how did this bogeyman come around? Well, I've got some theories on that, and it could be worthwhile talking about. But that's where I get to the point of saying, look, for maybe less than 1%, there's a real risk. You want to look after yourself. You want to stay away from this disease if you can. But for the rest of the population, no, it's not something to be terrified of. And that's why the Swedish response to this story has made so much sense, and why their death rates are so, you know, within the ranges you'd expect for a country with that age distribution. And much lower than the UK and the US, which have their own special features. We can talk about that detail. You know, and totally the differences that people point to between Sweden and Finland and Norway, which are much smaller than the differences between Sweden and the US, are largely explainable by the density of the capital city, Stockholm. Those gaps are closing. So, you know, it's been a very misunderstood disease. And we saw it in the NGOs when we were doing our research in the ground in Delft in particular, that just by virtue of our connections there, we were able to do some quite interesting, you know, on the ground research. We asked people how they were faring under the lockdown, and their answer was, it's dreadful. We're fearful. Our people are starving. The dogs are out on the street because nobody can afford to feed them. They're told a story of immense tragedy, and I'm talking now 2-3 weeks ago. It did not take long for conditions to go seriously south. And then when we asked the follow-up question, which is, what do you think of lockdown? The response floored us. These young, normal people who really aren't at risk for this disease all said the same thing. They said, no, the lockdown's excellent. This disease is going to kill us. This virus is going to get us. The government's protecting us. So a complete misconception of what lockdown was about and why it was being implemented. And this life of incredible hardship unfolding in a very real way. And yet they thought the lockdown was great. It was astonishing. Misinformation of epic proportions. So Peter, I think we haven't touched on the private equity industry. I mean, okay, do we need to talk about what an economic contraction does to businesses? No, I think everybody on this call knows. The one thing I would say is just be careful of the narrative of a bounce back. Think very carefully through your companies that you're invested in. If they're in discretionary spaces, think carefully about your target market. Is it going to be a market afflicted by reduced incomes? I would say that there are going to be a lot of businesses available for sale at bargain prices that are going to be interesting, tragic kind of circumstances. You will have a lot of entrepreneurs who've given up. So they might be quite dangerous investments from the sense that in small and medium enterprises that lose their leadership are often, in my opinion, untouchable investment prospects. Everybody takes their own view on that. Brave people will invest, that's fine. Don't pay too much. The other consequences I think that maybe our work would suggest might be in evidence is that this will not be, there will be a quick element to the discovery, but there will be a permanent element to the contraction. You know, so there could be a little V-shaped response as everybody goes back to work, but it's not a full recovery in a V-shape. I like to refer to it as a reverse tick with a very small little up leg to the tick. That's what our work suggests will come, and then the rest of the recovery will take decades. There's no question in my mind about that. What's the upside? Yes, I do. We do have an upside story, and we'd like to flesh that out. We think that this whole episode has laid bare a number of weaknesses in a number of areas around the world. The stories that come out looking very, very bad in this whole episode are your stories that involve centralization, whether it's the World Health Organization or heavily centralized medical systems like the ones that they have in Italy or Spain. The case for centralizing is being laid bare, exposed in a terrible, terrible way. The case for decentralizing has been looking very good. The German healthcare system, compared to its neighbors, has done a remarkable job. Their case fatality rates by age band are lower, so they're doing something. It's not dramatic, because this is a disease that's very hard to pull people back from the brink from. But they have done a much better job, a decentralized system, universal health insurance, tick. But what they have is a system of multiple hospital plans competing in the private sector. And one of the things that does is if you fragment your health system, you have each little plan has to keep more surplus capacity because you have a smaller statistical pool that they're treating. So they have to be able to deal with larger proportionate fluctuations in their ICUs, in their high care wards. So in a fragmented, decentralized system, you have more surge capacity. The system is more robust to shock. This is not the case in Italy. Italy had exactly the opposite. I mean, it's one of the features that's not spoken about nearly enough. Why was there this epic outbreak and this tragedy unfolding in northern Italy? Well, Italy has a massively centralized health system. For many decades, they've been investing in the south of Italy, not in the north. That's a political story. Politicians come from the north, need to buy support from the south, so they roll out infrastructure investment there. In the north of Italy, there's one of the world's most rapidly aging populations. So they've got a huge number of old people as a percentage of population. And all of that combined together to create the perfect storm. Similar, slightly different considerations in place in Madrid. And so you get these tragedies. Now, one of the things that has been an emerging tragedy elsewhere in the world is not overburdening of the health system, but an underutilization problem that's emerged because of coronavirus and lockdown. It's a real tragedy. In America, you've got acres and acres and acres of hospital wards that are empty and probably will remain so. And that's an unspoken about problem here. So, sorry, that's a strange way of talking about upside, but I think centralization is going to be something that gets properly unstuck. And that'll be a great thing. That'll be a really good thing for economic growth and for freedom in general. And I think that the other story that will be looked at very carefully is the role that we allow our politicians to play in our lives. I think whether you're looking at the Orange Man and his absurdities or our own politicians, the look is not good at the moment. The look is very much not good. And I think people will start thinking more acutely about what they can do for themselves and how, to what extent they should rather look to their local communities for answers rather than to central government. So I see that as a great story that could potentially come out of this. I also hope that people readjust their risk framing, because I think there will be some sense of embarrassment when the dust has settled on this one. We do need to start right-sizing our sort of risk radars, because the reaction to this thing has been in a kind of insane direction. It's really not a sensible approach. There have been very few sensible voices in the room, and they have not been amplified, and the crazy voices have been amplified shockingly in this whole process. So that's my upside story. But I'm an inveterate optimist. I think we will have benefits from this, but we're going to go through a lot of pain first. So I don't know, guys at SAVCA, can we call an end to our formal part of our presentation and start answering some of these amazing questions that have been coming up in the data room?
Yes, please. Thank you, Nick, and thank you, Peter. We appreciate you poking the bear this morning. We've had active attendees, and I think the first one I want to get to is a theme that's been coming through, and it's been coming through from Ben Cody Sang and an anonymous attendee. Sorry, anonymous, I don't know who you are. But really asking the question around the lockdown and why you feel that the government has not reacted sooner to the facts, specifically relating to the decreasing mortality rate. And then around Ben being the conspiracy theorist this morning and saying, look, if Darwin taught us that it's survival of the fittest, and so far lives lost and affected by COVID seems to be the marginalized, as you point out, the poor, old and health compromised, does it follow that the obsession with ending lockdown to save livelihoods is self-serving by the advantage? And while you're thinking about that, do you think the end lockdown argument is politically motivated? Trump seems to be defying data by rushing to open the economy in the midst of the tsunami. South Africa is a second-tier economy. The developed world will be okay, and hence motivation to return to work. The poor, which is the ANC's voting base, is likely to be worst hit due to poor access to healthcare infrastructure and food. And how do you balance these forces? And we're not done yet. Anonymous attendee getting onto that theme as well and saying, look, the reason government locked down early was to effectively stop the virus. That's his or her understanding, to stop rather than flatten. With flattening the curve, you would expect the timing of the lockdown would be taken 2 weeks before the peak. If it was given that the government had decided to have a lockdown, whether required to not, when would have been the best time to implement a lockdown? And just following up with biggest issue around the lockdown, or the idea of this lockdown and having jumped into the lockdown, ideally with the understanding that it was to slow the infection rate and provide time for reaction of healthcare facilities. That's the ideal, but that was not the reason. At no stage in time do we know or understand how to move back in to the economy. So we're going to talk about, let's talk about the lockdown first and all the questions that have been raised around the lockdown, the conspiracy theories around what's motivating the continuation of the lockdown. And then perhaps let's come back into these.
Okay, maybe Nick, maybe I'll start with some very high level stuff and you can then paint the picture.
Reopening what
Oh, sorry, I lost you for a second.
No, good, Nick.
Okay, so I think there's a retired former head of handling pandemics, or I can't remember exactly what his job title is. An old Swedish chap who's actually he's got a very, very nice way to talk about this stuff. And his biggest question, there's two things that he claims, is that the Swedish approach is based in science. Okay, so that one I tend to agree with him. But his biggest question, and I encourage you guys to dig up a news clip where he was invited onto a panel show in an Australian newsroom where they locked down pretty hard. His biggest question is, how does a politician get out of lockdown? No one thought about that question. I mean, this question has come up in the chat. No one has thought about, how do you politically get out of lockdown? Now the health ministry themselves have been saying that lockdown was to buy time. This is a flattening the curve strategy. South Africa has porous borders. We're very well spread. We're not an island nation. We're not New Zealand, where we can track and trace 3 million people and stop anything coming in. The virus is going to spread. Everyone concedes that, even the pro-lockdown policymakers. So when we made this decision to go into lockdown, no one thought, so okay, maybe I'll take a step back. Think about it politically now. So these deaths are going to come. I've honestly been gobsmacked and we haven't seen more. I don't know if we just have tough South Africans, but I was expecting more deaths by now, but be that as it may. So now let's say Cyril or whoever is in charge, I'm not sure if it's him, let's say they get us out of lockdown, we move to stage 2 quite quickly. Regardless of that decision or not, the deaths are going to increase. So, but people don't understand this. So what will end up happening is he moves to stage 2 or 3 or 1, hopefully 0, and the deaths will come. But the deaths are coming anyway. So politically, it looks like he's killing people because he moved out of lockdown. So that's the dilemma the rest of the world faces, that how do you move out of lockdown when things are going to definitely get worse in most places? And I don't know. I think hopefully the kind of evidence we're presenting is giving them something to blame us. Okay, we've realized poverty is going to be worse.
Can I just maybe take a definitely out of that sentence? Because, you know, one of the things that I'm intrigued by is how this supposed resurgence does not appear to be happening in the places that are ending lockdown. And I've had this personal theory. We didn't put it in the paper because there's not agreement inside our group. I'm a outlier in this regard. My personal theory is that the estimates of what lockdown has done and what the release of lockdown will do are grossly overblown. I don't think the characteristics of this disease are really supportive of lockdown having much effect. So you're seeing now, you know, Spain has been emerging from lockdown for more than 2 weeks, and there's not much going on by way of a sudden explosion. And kind of, you know, people have been routinely wrong on this. You've got to accept it now, guys. You know, we watched over the last 2 weeks as the death rate in Sweden declined. And every 2 days, The Guardian was pumping out an article shrieking at the top of their voices about how Sweden was facing an epic disaster, and tomorrow it's going to go, and tomorrow it's going to go up, and tomorrow it's going to go up. They were literally publishing an article every 2 days during the 12 days in which the death rate was coming down in Sweden. That's what I mean by this collective madness. And people just would not look at the data, you know, just refused. No, Sweden's not in lockdown, it's going to be a disaster. So I'm actually a little bit skeptical about this idea that there will be an explosion. I'm not too sure that lockdown was effective. So there is a diversity of opinions here. I would not bet a large amount of money on this question. Don't get me wrong. It could be that there has been an effect, and I'm open to that idea. The data will tell us. Yeah,
Nick, I think we are actually on the same page. I don't think lockdown's making any difference, but I do think we are going to have a wave. Not a particularly huge wave, but the wave is coming. So my point is that stopping lockdown and the wave coming irrespective is just going to make it look like stopping lockdown caused the wave. And I'm saying it's coming irrespective of whether we stop or not, which makes it
I agree with that. I agree with that. Peter, don't you think Ben's question is very interesting? I mean, Ben, you must be a philosopher by training.
Remind me the question.
He was asking about the Darwinian story and you know, how you evaluate one life versus another. Yeah, we did have this discussion. We were quite cautious to present our works without any such interpretation. So we just wanted to put the answers down, and then people can make their own assessment. You know, the philosophical questions are interesting. You know, we're talking in part about deaths in the future versus deaths now, which raises the very strange philosophical question: at which discount rate should you apply to mortality? And there are people who believe, like me, in a zero discount rate. That's just my personal ethical stance. And there are other people who believe in very high discount rates, like a death next year. It doesn't count at all. It's all about this year. It's all about today. I battle with that personally, but I realize that that's just an ethical stance, and I'm not there to judge that other person. I'm uncomfortable with it. But we didn't want to be in that domain of playing judge and jury and executioner, as it were. So we presented the numbers and allow people to make that interpretation themselves. I do want to pick up on this idea about the class story, that it's the advantaged people wanting to end lockdown and the disadvantaged people who are going to bear the consequences. We actually think the story is the opposite. So the consequences of lockdown, as Peter said in his discussion, fall largely on the poor. We think that, you know, it's a notable feature that the loudest voices are people who have what economists call fiat jobs. In other words, jobs that are not at risk to any real economic pressure. So that would be your government employees, your university employees. They're not worried about getting fired. They think their jobs are safe. They may not be, because tax revenue is going to go down, but that's their feeling. They feel comfortable. They're the strongest voices against the end of lockdown, okay? And that's a very interesting social phenomenon. But the reason we say that there are a couple of aspects to why this doesn't fall equally across the social classes. First of all, obviously, your older people tend to be in the more wealthy groups, okay? The reason for that is the reason they get to old age is they have less exposure to disease, better nutrition, better diet, better healthcare, okay? In fact, one of the political concerns we had, and we raised this right at the beginning, was, where's Julius? When the deaths start coming out here, there's a real danger that this will look like the deaths here are affecting minorities in this country, and that the consequences of the actions taken to protect those minorities are being felt by the masses. And we thought that that was a potentially very divisive and very dangerous narrative that could emerge, and we're quite surprised that it hasn't. The point about access to healthcare for poor people who do contract the disease, that is an extremely valid point. But bear in mind that the age distribution and the distribution of the comorbidities in that grouping makes them statistically less at risk. So totally agreed, once they get the disease, they will have, on average, poorer access to healthcare, and that's bad. But they don't face equivalent risk to a 78-year-old in Sea Point who's been kept alive despite having 5 or 6 comorbidities. And you know, I'm not exaggerating there. The data is that 60% of the deaths in Italy had 3 or more serious comorbidities, and 97% had 1 or more. So you are talking about are very often people who are alive because of medical science. So they've had access to healthcare.
So Nick, you know, just interrupt you there for a second. That ties in neatly with the question that Craig Benny had, where yes, you said in your presentation that you sense that HIV and TB are comorbidities, and whether you have any empirical or anecdotal evidence for or against that sense.
Okay, so
let me tackle the HIV one, Nick, and you can do the TB one. Yeah. I think the government's missed a trick on HIV. There was a massive opportunity with this virus. So what we're seeing is that if you are disciplined about your ARVs, which are, I mean, for what it's worth, the government's done a great job over the last few years of distributing and making it free and accessible. And I mean, in the insurance space, about 3 or 4 years ago, we started offering normal terms to HIV positive people that were on treatment, because it literally makes no difference to their mortality versus any other kind of chronic disease. It's become like a chronic disease these days. In many cases, you can't measure the CD4 counts are so good. There's no viral load, so you can't even measure it. So we don't know for sure. We suspect that if you have a low CD4 count, which means your immune system is pretty shattered by HIV, which is only happening in cases where you are not on your ARVs, you are most likely, I would count that for caution's sake as a comorbidity in this disease. Maybe it isn't, but there's a good chance it is. So I think the government missed a trick to actually drive a proper, get tested and get on your ARVs, because that might save your life here with COVID, because it is absolutely preventable if you actually get that treatment, which is free and works. We know it works. So I mean I do think if you're not being good about your disciplined about your treatments, you probably can count it as an ARV. So I would personally say untreated HIV is a comorbidity. If you're on treatments and you've been good about it, probably not.
Yeah, and the question of this unmanaged HIV population is a very interesting one. It could be anywhere between 500,000 and 3 million people who are at risk in this regard. They would be expected to present clinically in a very different way from normal coronavirus patients. That is true for almost any unmanaged HIV case. You know, when these people with the very low CD4 counts, when they die, you take a blood sample. That blood sample is like a petri dish. It's got dozens of diseases in it, and it's been commonly observed by doctors who are specialists in the field that, you know, for example, TB will present very differently in an unmanaged HIV patient, and it's very hard sometimes to exactly determine the cause of death. So, I mean, these are people who are very vulnerable, can be taken out by almost anything. And I think it will be the case, one of those cases where it's very hard to attribute the cause of death. Is it coronavirus, or is it one of any other 20 diseases that are in the patient's body at the time? It is a tragedy. It's to me beyond appalling that there is still a stigma attached to HIV. And that is the cause of that tragedy. I think the main cause of that tragedy is people don't want to acknowledge that they're HIV positive and go on ARVs. It's free. It's been free for a long time. And it is a great sadness that this country still has a stigma or certain elements of the population still have a stigma attaching to HIV. And you know, Peter's absolutely right. I mean, you could do it today. If we started that story today, in 2 weeks' time, the person who's on ARVs got much better chance. The CD4 counts rise quite quickly. They rise so fast that there's a syndrome associated with it called immune recovery syndrome, where all the diseases that they've picked up because of the weak immune system start expressing themselves as the immune system starts recovering and takes them on, you know, because that's the problem. The immune systems don't respond to the diseases, so they just float around in their bloodstream and in cells. So you get this immune recovery syndrome. That's how quickly ARVs operate. So Peter described it as a missed opportunity. It's not missed past tense. It's being missed. We could still roll out at a fraction of the 500 billion rand a resumed impetus to get people onto ARVs. And I think that's the right policy response, not continued lockdown. The TB one is very interesting. The reason we are not seeing that as a risk factor is there are other countries in the world. We don't have to learn from our own population only. Indonesia has an enormous TB prevalence rate, and lots of them are very poorly managed cases. And they have not exhibited a different pattern, age distribution of cases from what you'd expect given their population. And the information is a little sketchy. They don't have a lot of great data, so we are getting this somewhat anecdotally. But as far as we can tell, there is no unusually high death rate because of their advanced TB story. And just bear in mind what we spoke about. It's not a lung problem, it's a vascular problem. It's endothelial weakness. And that's not a marked feature of TB patients. So there are clinical reasons why we wouldn't expect it, and there's statistical reasons why we don't expect it. Again, this is all in the nature of conjecture. You have to put up your theories and then test them as the data emerges. It's the only way that science progresses. But at the moment, our conjecture is not being falsified by the data in South Africa or elsewhere in the world. I agree with Peter that the HIV thing is an issue, and that would probably rank as a comorbidity. It could be emerging that way. We don't know if it's all of the unmanaged cases or some subset of them. But there again, what's the right policy? Surely the right policy is to get those people onto ARVs, fraction of the cost of lockdown. So very interesting field. I'm so glad Craig did raise the questions. We could have gone on a long time in our report. We didn't, because sorry, I should maybe mention that as well. The years of lost life for an unmanaged HIV case with low CD4 count is very low. So, you know, that person is exposed to dying in the face of almost any opportunistic infection. And so, you know, their years of lives lost if they do get infected and die because of a coronavirus infection is low. So it doesn't change this type of analysis. And I apologize again for talking in the cold-hearted actuarial way, but that's just the case. They don't change, even if there's 3 million of them, they don't change the answer.
So Nick, maybe let's just stick with this trend for a moment. Sam Pockroy from Sonari had a question around whether there is evidence and research indicating the extent that psychological stress arising from poverty and or financial distress has on mortality.
Peter,
did you post that article to the group the other day?
Yeah, there's a very, very, very clear link. So I mean, as this group has emerged and become a bit more public since late Monday, we're getting a lot of interesting data getting given to us. I mean, shared with us on a please don't share further basis. So we're getting, it's quite interesting how much people are saying, I'm seeing this particular thing, would this be useful to your thinking? And the one which I found fascinating is that there's a business, I'm not going to go into the details because I don't want to give it away, but tracking, it's heart rate tracking, data coming from heart rate monitors of people's wearables. And in South Africa, they are seeing such a marked deterioration of people's heart metrics from this financial stress. These are middle market people. This is not poverty. That they actually getting doctors to phone these people to say you need to get help because you're not sleeping and your heart is under massive stress. That is an anxiety provoked thing. And I think one of the things that will emerge, and then anecdotally we are hearing about suicide spikes. that one I wouldn't lean too hard on, because we don't know the base, what would suicides have been normally. But I would not be surprised if suicides are going to rank quite highly over these couple of months. And we know financial stress leads, and in the insurance industry, we know financial stress. We are going to get more suicide claims and depression claims on the disability side. That we absolutely are anticipating. So there's no doubt it's going to have an effect. On the poor side, I mean on the lower end of the socioeconomic spectrum, I would expect that to express more in substance abuse, which immediately has deteriorating health impacts too, and then it also leads to the social fabric issues. I mean, we also have a data point that the call center that takes in calls for child and domestic abuse has had double the calls over the period before lockdown, and that data point is 3 weeks old. So who knows what it is now? So there are some incredible effects that we haven't even taken into account here. And I mean, I haven't got a huge team, but I've got a team of about 50, and I can see people psychologically breaking down, not because of money. These people are being paid. I mean, we haven't cut pay in my team, but they are living in fear that they are going to die from this virus, and worse, they're living in fear that their children are going to die. And that is just an unacceptable level of miscommunication. I've actually had to phone a lot of them and said, listen, I have the data. Your children are not going to die. I guarantee you, they will not even get vaguely sick here. So just do yourself a favor and don't let that worry you, because that is just anxiety that manifests in really, really horrible ways medically. So yes, I mean, long answer, but we haven't taken into account because it would just make our case stronger. But absolutely, this is having a negative effect.
Yeah, there have been two scandalous misreportings of this in the South African press. News 24, City Press, both deserve a public mocking session. The article, I think, from the day before yesterday in the City Press, if you send your children to school, you're sending them to their deaths. You know, I mean, in my mind, that is just, it is unethical journalism that is just completely off the charts and just scandalous. It's just so disappointing to see that. We have responded to both of those. No response from the editors, nothing. You know, they just don't care. They don't give a damn. And it's just really disappointing to see. But to Sam's question, hello, Sam. I used to work with Sam in New York. We had a very interesting little anecdote. Peter talks about this information that drifts through. I don't know if it caught anybody's attention, but there was a report in the Washington Post of 4 stroke victims in their young 40s, all men in their young 40s. And we looked at that and said, oh, because the idea was, and they were all corona positive, okay? And we looked at that and thought, oh, that's a bit surprising. Why on earth would that happen, you know? Okay. So let's see if we can find out. And I picked up the phone to a relative of mine who's a medical person in the US and said, what gives with this story? And he said, yeah, what they're not telling you about is that there have been 80 stroke victims of young age, unusual number of strokes. And that's just the portion of people in the population who are corona positive that they're reporting about. So in other words, there was a false association between the virus and the strokes. The strokes are happening because of stress and strain, largely associated with the economic consequences of lockdown, to a lesser extent with the economic consequences of the virus. And I think this stuff's very real. We are the combination of months and months of isolation and stress is going to do very strange things to people, I'm afraid. And I think we will see it. One of the things I actually expect is that when you look back on the year, the impact of coronavirus will be probably detectable, but not that great in terms of world mortality. But next year, non-coronavirus deaths will be extremely visible.
Yeah, I think there was a question about conspiracy theories. And I mean, I don't really want to start blaming Bill Gates and things for things like this, but I have absolutely no doubt that the media, for whatever reason, are doing better by overhyping this thing, and it's completely unhelpful for the anxiety levels. And I'm talking more international media. It's true here, but we're not alone. there was an article. So when I'm very, very vocal about your kids are fine, that message. And so I get sent the nonsense without unprovoked. And the one I got sent the other day was an article. The headline said, "Children are now having this incredibly rare disease emerge." Okay, so it was quite, there was a warning had gone out to all doctors in London that this is now happening and be careful. That was kind of the headline. I was like, okay, well, let me read that and mind it. In the article itself, it said, funnily enough, children without coronavirus are also getting this thing, and it's very, very, very rare. So basically, it's a thing, has nothing to do with corona, but the headline is that corona's causing more stuff in kids. And there's another, well, I can't remember the name. It's a funny name disease that kids sometimes get. Sounds like it's named after a German doctor, but there's a report, oh no, we're seeing cases of this thing. Yes, well, you do. That happens. So the media tend to kind of just paint everything with this corona brush. And it's appalling. And it's the US media, I think in particular, have done a lot of damage here for people's mental well-being, actually.
Thank you for the clarity, Peter and Nick. Maybe to get, there's a lot of agreement around the point about the media, but maybe just to move on to, and maybe before we do, guys, this would be a lot more fun if you were to put your hands up so we can unmute you and you can ask your questions directly. So please consider joining the conversation live. But we had a comment from anonymous again, Nikita, and from Gareth Truce. But anonymous, I think most of your questions have been dealt with. I think the one that isn't is, what is the solution here? Do we just lift lockdown? What is your premise? And Nikita asking in the same breath, saying, look, if decentralization is the positive upshot of this pandemic, it means the poorer regions have to find their own resources to cater for their overcrowded hospitals, as opposed to having central government reallocate resources to those that are most in need, and whether you have a comment on that.
Yes, we are drifting into the domain of political theory, but it is such an interesting question. I mean, yeah, clearly the allocation decision can be separated from the administration decision, as it is in Germany. So there's not. I think it's helpful to make that separation. You can do a transfer of money, but the implementation at a local level seems to me to be an incredibly strong theme that's emerging. The decentralized health systems are just doing much better in terms of case fatality rates. I'm amazed that I've seen one article on it, and it was a very persuasive article. I think I'd be hard pressed to find it again, but I think this is going to be something that will be studied closely. The reasons given for why France and Italy and Spain have done worse than Germany, I think they verge on the racist almost. You know, it's not all down to the fact that Italians like hugging everybody and Germans are cold. No, there are deeper reasons at work here, and they're to do with the way they articulate their economic system and the way decisions are propagated through the system. One of the real problems here with the centralization is that what centralization does in this kind of situation is it destroys the means of error correction. If you have 50 states in the United States all doing different things, then you can look over the border at the next state and it does something different. Then the other state can say, oops, let's do that. Let's stop, let's do that. Okay. But if the whole federal government mandates you to do it in one way, you get no error correction happening. And that's our problem. One of our problems in South Africa is everything's done on a national level. There was some talk of staging it differently in the different provinces, which sounded very iffy. But apart from that, everything's been done. And one point that somebody raised earlier, which I thought was really good and we should have picked up, what on earth were we doing going into lockdown before there'd been a single death? What that did was rob us of the chance to see how the epidemic was playing out and knowing where the resources were going to be needed and so on. So it would have made more sense in my mind to let the thing flow. For all we knew, we were never facing big numbers. You know, just the fact that there's a model out there predicting 50,000 deaths doesn't mean there are going to be 50,000 deaths. So allowing a bit of ramp up until there started being signs of pressure on the system, and then locking down would, in my mind, have made a lot more sense. One, I'll tell you this right now, a potentially embarrassing outcome here is that you end lockdown and there's no ramp up in infections, and ultimately this thing peters out without a very large number of deaths. That is, it might not be your balance of probability scenario, but it is very different, definitely a plausible scenario. There's a clinical story that you can tell to support that scenario in South Africa. And it's a scenario that's played out in other countries already, where the infection's gone around and they've hardly had any deaths. It goes to those questions of what are the features of your population? How old is your population? What is the diet? What are the chronic morbidities that are prevalent? People look at Vietnam and talk about the success of test and trace. There isn't something to be said for it, but let's just be realistic. It's a very, very poor country. What went right there? They have the lowest levels of obesity in the world, 2% relative to America's 40%. And a lot of that obesity that they have there is genetic, different kind of obesity to what you get in America, which is lifestyle, to do with eating too many carbohydrates, that kind of thing, and damage to the endothelial lining, which is the problem for the disease. So, and South Korea, again, great, yes, another country with great test and trace, 4.7% obesity, different diet. These are all the factors which will begin to be understood afterwards. And in the absence of knowledge of those factors and how they affect each country, you have to be very careful about what you're predicting. So I think there is actually a possibility that this story doesn't get that big in South Africa.
So a reminder, guys, we've run on to 25 minutes past 10. So we've got 5 minutes left, 5 minutes left to answer questions that are open. And I think the one that we haven't answered is, so what do we do? Do we lift the lockdown in entirety tomorrow? Do we forget about the alert system or the plan that we've got in action now? What are your thoughts on that question, gentlemen?
Very quickly, I'll let Nick answer, but my thoughts is that we lift it today, not tomorrow. But I'll let Nick finish. Yeah,
10:30 would be a good time. I mean, when you have a number which conservatively says that the loss of life is 30 times what we stand to lose in the epidemic, let alone in, that's not answering the overburdening question. I think this is just such a compelling case. I don't really understand. I mean, yeah, lockdown should have been dropped after the first, and we have the consequences. And yes, could we prepare more? Sure, of course we could, but at what cost? What we framed with our work here is the immense human cost of continuing each day of lockdown. And just remember, our calculation was that a week of lockdown is equivalent at least to the total mortality from the disease every week. So my argument to policymakers would be, come and show us where our calculations are wrong, and come and show us today, because if they're right, you need to end this thing now. And so far we haven't had actuary, epidemiologist, virologist, statistician, economist come and say to us, oops, over there's your 1 order of magnitude error. That just doesn't happen. Have we lost Melanie?
You're on mute.
Oh, I'm so sorry. I've unmuted myself. Sam Pockroy has a final query on that. Is it possible, thank you for this, Sam, now you're making me pronounce it. Is it possible to test for endothelial damage so that we know who does or doesn't have a major risk in regards to this
answer that. So
virus?
I think it may be, but the problem is that it's much easier to predict it. So we got to remember we're dealing with 58 million people here. We can't, if there was a test, there's no ways we could possibly test 58 million people for this damage. So this is what we would do in insurance, to say, well, there's actually a correlation between these 4 things and that damage. So rather just worry about the things you can identify immediately. So if you've had diabetes for a long time and are obese and have hypertension, and there's a list of 5 or 6 things that are kind of contributing factors to that, that's probably the easiest way to say you should consider yourself at risk versus you should consider yourself at no risk or low risk or negligible risk. And I think that's kind of on a not on a macro government level, but I think treating people, letting people decentralize their own individual decisions with accurate data. If people know they're at risk or don't know they're at risk, they individually will be better at making decisions for themselves than the government will be centrally. I think that's fairly clear, but it doesn't help that when everyone thinks they're going to die and that information is not out there. So that's also part of what we would propose, is that let's start treating people like adults. Let's encourage the wearing of face masks. Let's still ban massive gatherings. I don't think we need to see the Stormers again this year. So those kind of things are fairly low cost. I mean, they are actually very low cost. There's a small impact, but there's plenty of low cost interventions we can still do, including encouraging ARVs treatment, that actually maybe net gains overall, probably would be, that doesn't push millions of people into below the breadline.
Yeah, I've got an appeal actually. Do you mind if I just take a couple of minutes, SAVCA, just to launch an appeal here to the members of the webinar here?
Go for it.
Thank you. The first appeal is to everybody to apply their minds to creative solutions. It's so disappointing that we haven't come up with a uniquely South African response to this tragedy, that we've just simply aped the decisions of the communists in China. That's just a crazy point of departure in my mind. And it's so disappointing for me because the good ideas are coming in from the outside all the time. We've got one of the doctors on our team threw in the idea from Australia. He said, well, you guys have got a state old age pension. Why don't you triple that? And we did the maths and we thought, yeah, that's not such an expensive initiative. And it makes a lot of sense, because the one worry you have is that poor people do not have the ability to self-isolate. So they're at-risk old people amongst the poor, okay? So triple the state old age pension for the next 3 months. That enables them to buy access to childcare, because a lot of them, because of the heinous failure of the Mbeki administration to roll out antiretrovirals, they are looking after orphans, okay? So triple the state old age pension, they can look after themselves, they can pay for somebody to look after their children. Now, okay, is that the most practical idea in the world? I think it's a pretty good one. I think it's worth thinking about. I think it's worth exploring. But my point is that we have had a complete failure of such creative ideas. Another one would be pay people, if they want, to come and stay in all our unused hotels. You know, tot the cost up, bearing in mind how big we think the quantum of the at-risk population is. Giving people the option of coming into a quarantine environment, pay them 5,000, 4,000 rand a month, whatever, they'll do it. Feed them a square meal. I'd imagine there'd be some poor people who would do that and would provide them the opportunity to be protected at much lower cost than the packages we're throwing around now, and which we have to throw around mainly because of lockdown, not because of coronavirus. So there's all sorts of creative interventions that I think are being missed here, and ordinary people will come up with them. These very dirigiste government type people and men in white coats, they're not going to be the ones who come up with these ideas. They are not going to help us. They're too busy shutting down pies and chickens and cigarettes, okay? So I would appeal to everybody to not take the approach of leave it to the virologists. Please just apply your minds, throw the ideas around. We've got to be able to come up with uniquely South African solutions. So that's appeal number one. Appeal number two is I want everybody in this audience to do one of two things. Either to decide that there's something wrong with our logic and to write to us and explain to us what we need to reassess, or to decide that it's correct, maybe having read the paper. And having decided that it's correct, there is no excuse for not becoming an activist in this cause. This is end of day stuff for our country. This is not a little economic hiccup. We are heading south very, very fast, and it threatens all of our futures. So there's no point running around doing your deal making and fixing your companies and attending the board meetings if we are going down that track and we are right. It's an obligation of everybody to either respond to this paper and point out to us where our errors are, or if you think it is true, to do everything in your power to put pressure on government to end the lockdown, and I would also say to try and ease our way out of it. And then the other little appeal I have is, if you are one of the many people who find themselves not so busy at this time, if you have skills that are relevant to our efforts, please drop us a line. We are short at the moment of a few modeling people in particular. We're looking for Python modelers, because the other leg of our work, which is more exciting than the first one, we would like to get to market with next week.
Fantastic. Thanks for that, Nick. I've just asked you guys, how do they get hold of you? What your preference is for them to get hold of you. Do you want to share that with us?
Yeah, I'm nervous to put email addresses out in the public domain for obvious reasons. We are besieged by information at the moment, so they can get in touch with you and get my, you can give my email address to anybody who wants to get a copy of the paper. I'll leave it to Peter to volunteer that if he's happy with that. Yeah, if you want to address technical questions about the paper, then Peter's definitely the man. I'm a little bit clueless on all of the underwriting assumptions and so on that went into the engine room of that model. So I don't know, Peter, are you comfortable?
Yeah, that's fine, 100%.
Yeah, so happy for, we're also out on Twitter. I'm Nick Hudson CT for Cape Town. Both of us are on LinkedIn. We will have a website soon. We will have a LinkedIn group soon. We're just catching up with ourselves a little bit at the moment. So yeah.
Fantastic. Thank you, Nick. So I know, Craig, Benny, you asked another question. What I'm going to do is I'm going to ship that question off to Nick and Peter post this webinar, and they can get back to you directly. And in the interim, you've got your participants to do. And if you've got skills or time and you're supportive of PANDA, please share those time and skills with Nick and Peter. I want to thank each of you again for energetic. So thank you for joining us this morning. And Nick and Peter, thank you for your time and your insights this morning. Much appreciated.
Thanks for the opportunity.
Yeah, thank you.
Thanks, everybody, and see you on our next webinar.